It's always a pleasure to be back in Bern. It's one of my favorite cities in Switzerland. I'm here to speak about health literacy, gezondheidscompetentie, gezondheidsvaardigheden in Dutch. I lived 10 years in the Netherlands, but my German is not good enough to speak to you in German today. I could have done it in Dutch or Danish, but I think the translators would have an issue. So I will do it in English. We are faced with so many challenges. The refugees coming from Africa and from the East, and it's a big challenge for our healthcare systems in Europe. Non-communicable diseases, this was Ebola, but we have also the flu. Non-communicable diseases, chronic diseases, diabetes, mental health is a burden for our system. Trying to stay healthy, trying to avoid being obese, trying to avoid smoking, drinking, and so on. We all know what is right, and then we do something else. We are over-informed. One of the other speakers talked about being that the patient would know more than the doctor because she had a fast modem. We are so overwhelmed with information, but we're not very good in actually judging if it's good or relevant. We are challenged with resources. This is a new model of a Professor Kate Raywood from the US called the donut model, an economic model. Thinking about climate change, that on one hand, in the inner circle, we want to ensure that everyone has food, education, have a voice, have jobs, that we have good energy, good social equity. That's the basic rights, basic foundation for a good life. That's the inner circle. On the other hand, we also know the way we live today is putting a burden on the earth as we know it. And we have started to talk about planetary health, really. But why I want to show you this model is also because I think we can apply it to the healthcare system. On one hand, we all try to ensure that everyone gets the right access to health. And on the other hand, we also know there is a maximum for how much we can enlarge the outer circle. And most systems today in Europe are under constraints. So let's remember this donut model for the health system. But what is health literacy and why does it matter with all these challenges? I want to show you some slides from Australia. So it's an Australian campaign, but I think it shows very easily here to what is health literacy. It's about your own health. It's about how you understand information. It's about how you make decisions about your health. It's about how you involve others in your decisions, or if you are involved in health of others, could be family, could be colleagues, and how you take action. And it's about how you feel about yourself and your good health. It has two sides, an individual side and the environmental side. I usually say it's one coin, two sides of one coin. We have the person in the middle with the skills, the motivation, and the knowledge to take care of good health. And then we have the system, the society, and the opportunities that provides and the services we have, but also a lot of the barriers that have been mentioned earlier this morning. These are the Australian figures for people having limited health literacy. It shows that 60% does not really benefit from the services, and they have trouble managing their own health and take decisions and judging the information and using it. Only 40% can actually make use in a proper way for themselves to be happy. And why is it important? It's because we know research has shown that those who have a low health literacy, they will often feel much more worse in terms of their own health. They will often call an ambulance and use emergency care much more than others. It's apparent in all people's lives, and those with limited health literacy have difficulties in managing disease and managing medication. They are not using preventive measures the right way, and they don't always understand what is going on when you try to explain it to them. And they are often being hospitalized. We know that from research. And in recent years, more than 6,000 papers have been published, if you go to PubMed and Medline and so on health literacy. So the evidence is growing in terms of these aspects. So what should we do about it? Well, some of it is to involve people as consumers, because it's not only when you're ill and you're in touch with the healthcare system, it's also when you try to live a good everyday life. So we need to support how they seek information, how they understand it, ensure that we can be open and honest and not stigmatize anyone, and ask if they want different kind of explanations, different choices that would match their needs. But it's also a task for clinicians to be involved and to recognize that there are these differences in limited health literacy and high health literacy. You need to know your patients. And we know the way that health systems are organized today, it's really difficult because there is so little time and so few resources. Some are good at it, some where it really faces a problem also for the patients to navigate under these time constraints. Consider what kind of information you give. If it's full of medical jargon, there is a high risk that they will not understand, and we need to speak in a much more simple language. And when I was at medical school many years ago, it was not taught the simple language, it was taught the medical jargon. So it's kind of a learning, de-learning, and relearning process that we have to go through a new language in a way. And you can become, as a profession, very blind to your own way of choosing the words. And we do have to keep checking if they understand it and try to improve it by giving courses, adult learning courses on the health education in schools, and so on. But it's also a management issue, because if we have organizations that give us all these constraints, it becomes very difficult, and we need to have the people on board who actually make the priorities. We need leadership. We need to put systems in place. We need to partner with people, with patient organizations, with consumer organizations, those who know best, as we heard this morning, and try to build on co-design of our systems. So this was the way that the Australian Commission on Safety and Quality in Healthcare did it. And there are several other examples, but it's something we can learn from in Europe. Because what's the situation in Europe? When I came into the field back in 2009, we didn't know anything about health literacy in Europe. I got engaged in the European Health Literacy Project to try to explore what the levels were in Europe, how we could manifest it, because we knew from the US it was a big problem. So in 8 countries, we had partners, and with support from the European Commission, we decided to look at how could we understand health literacy in a European context. And the first we did was to make a review of definitions. It was kind of the same feeling as what we heard about before with the interdisciplinary term. We had the same exercise here for health literacy. And eventually we combined all the definitions. We found to this all-inclusive definition that says health literacy is linked to literacy and entails people's knowledge, motivation, and competencies to access, understand, appraise, and apply information to form judgment and take decisions in everyday life in terms of healthcare, disease prevention, and health promotion to maintain and improve quality of life during the life course. It's kind of a research definition because it's so long, as you can hear. But it also says clearly that we distinguish literacy and health literacy. So literacy is more what you learn in school to read and write, count numeracy and so on. And health literacy is really within the healthcare field in a way, the realm of health. We also say here it's more than knowledge. It's also the ability to act, the competence to act, to find, to understand, to judge, and use information to take decisions in everyday life. So again, we're out of the healthcare setting. We're not only in the healthcare setting, it's also when you're at risk and when you try to stay healthy. And we have this interaction between the individual level and the societal levels with healthcare prevention and promotion. And we say that health is not the end, it's actually quality of life being the end. So it should be a means to improve quality of life, and it will develop through the life course. Another way of describing is our conceptualization of health literacy, where you see from research that we have the core, finding, using, judging, and also finding, understanding, judging, and using information in the different domains. And we see to the right-hand side that personal factors will influence. Makes good sense. How old are you? What's your religion? All the socio-demographic factors. But also the situational determines where you live, where you work, and the broader societal factors, which country do you grow up in, which world region do you grow up in. And we see that what you saw from the Australian campaign, it has an impact on health service use, health behavior, how you are able to participate in health activities, and it has a strong social gradient. And we can look at it at individual level as well as population level. So we measured health literacy in Europe, and we had the same, unfortunately, the same result as in Australia. The Netherlands did the best with the longest green bar, and Bulgaria the worst. So it's between 1/3 and 2/3 of people, 8,000 people we had in our sample, that had difficulties in managing their health and managing information and navigating systems. That came as quite a surprise for us, for our stakeholders, for our politicians, because they said we have a good welfare system in Europe, we have good educational systems in Europe. But how come that this is here? Why is it? And we have no clear answers, but it certainly has a strong cultural component. It depends which country you're in. And we know that Netherlands has a very flat structure and very informal structure where people have very easy access to health, whereas in Bulgaria it has been much more top-down and not so elaborated and developed as in the Netherlands. We don't have much economic data, but from the US they say that it's a very major source of economic inefficiency in the care system, and they estimate that it costs 106 to 238 billion annually because of this mismatch between what people need and what we can offer, and because of people's abilities to manage their health. Some of the percentages we hear from Europe are between 3 to 5% or even 10 to 15% of health budgets and personal budgets that this costs. So it's a huge economic drain. So we keep talking about it as a burden because we are there as decision makers, we are practitioners, but we should try to look at it as an asset and try to build on people's skills, build on their capacities. I mentioned there was a strong social gradient, and it means we need to talk about inequalities and poverty because it plays such a big role for health literacy. These are the extremes in Brazil where you see the slum areas and you see the rich areas. And you think that poverty doesn't exist in Europe. This is poverty. But unfortunately, all the new research we have show that it also exists in Europe. Some of you may know these tube maps where we know the differences in mortality from one station to another or from one area. This is from Scotland, but we have it also from Copenhagen. That if you are in the south, you would have 10 less years than if you live in the rich north of Copenhagen. And you can see here the differences for females and males. And even though we knew that, it was kind of a research knowledge that we knew this, but in Denmark last year there was some television documentaries that gave it life, this discussion. In Aarhus, where I just moved after 10 years in the Netherlands, they showed that not even in different quarters of a city, just one big road cutting through the city from the center to going outwards. You have flats on one side and you have big villas on the other side. And really, it's one road, but two different worlds that these people grew up in. So you have here the family living in an architect-designed, very fine villa. You can see that they wear very nice clothes. I know the Danish brands of this designer clothes. And then in the villa, you have a family who doesn't earn a lot. He's not working, or he has temporary jobs. She's working, but she had a birth defect with her arm, so she's handicapped. You can see the clothes are second-hand clothes. It's a very small apartment, and they live many. When you zoom out, it's just apartment after apartment after apartment. And you start to feel sorry for them. But actually, when we see the documentary, we see that they have a lot of assets. They want to do their best, but it's a system that keeps giving this family in the flat barriers on barrier on barrier on barrier. And is there a way out of it? Actually, the father living in the villa, he grew up in the flats. So he tries now to teach his children how you can actually move and change your own situation. And he's a football trainer for the kids living in the flats. And it gives us some insights in the dynamics on how does that influence quality of life and the health. You can tell that the family in the flats, they have so many health problems. Multimorbidity is one big stamp in their family. Mental health, physical complaints, a lot of medications which they can't afford. Another study moving just 1 hour up north to Aalborg in Denmark in the north. You see it within the same zip code in one deprived area with a lot of different ethnic groups. There are 10 years difference for women in mortality and 13 years for men, even though it's a distance of 7 kilometers. And when I'm confronted with these numbers, I just think this is not good enough. I'm not proud of it. And when I had a discussion with Danish politicians, they keep saying poverty doesn't exist. We're a rich country. We're actually the most happy people in the world. But there are some that are more happy than others, based on this research. And you can just see the consequence. We know from the health literacy research that those with low education, low social status, elderly, different ethnic groups, they have a higher burden than those who follow, let's say, in the mainstream. And when I see this picture, what do you think of this lady living in the flats? She doesn't look happy. Her eyes are like, she looks hopeless for me. And they zoom in on her and she says, I just went to the doctor and he gave me a phone number, but I have this long list of phone numbers I get every time and I just don't know where to start because every time I have to call the social worker or a new nurse or a new physiotherapist or the pharmacy, I have to explain my situation all over again so many times. And actually, I don't even have the budget for financing my medicine. So every month I sit and have to decide, what should I buy, what should I do? And then the interviewer said, did you tell the doctor this? No. Because she doesn't have the time to do it, there is not the trust, she doesn't feel understood. But then, in the documentary, her son comes in, and there is an interview with the son, and he says, oh, I'm so proud of my mother. She's really coping so well with this situation. We are under so much constraints, but I love her, and she's doing her best. And that's what we have to remember. Try to look at it as an asset that we can build on, that people are proud. We love our family, we love to care, and we have to build on that when we think about strategies. And it's a triple burden for a lot of people. They're poor, with many resources, they have a poor health, and they have a poor health literacy. And that's a fact when we meet them for 10 minutes in our consultation. But we forget it because we often zoom in on what is there as a symptom. But they are people, they have lives, they have families and relatives. We have to have that picture in our mind when we try to help them, to leave no one behind. And that's what it's all about. It's a challenge we cannot neglect. We need to make our system much more people-centered than what it is today. We try to humanize it in a way. And we need a turnaround, really. I don't know much about the Swiss system, but the Danish system is called sick. That was the headlines 2 weeks ago, because of the pressure. So we need to focus on the people, need to focus on the experiences they have, their values, their beliefs, what we heard about this morning. Previously, in health literacy, one of the models that have been shown is this one, and then there is a circle in the middle saying health literacy, where it's about having people's competency to match the complexity of the systems. And we tried to work from that for a long time. But it's also given a worldview that we're then blaming the persons or the people for not having the right skills, because the system is as it is. It's complex. And we have to cope with it. That's been the view. My dream for the future is that we make a turnaround, that we look at people's complexities and design a system that has the skills to deal with people's complexity, not the other way around. That's my mission. And how can we do that? Well, the paradigm is now that we try to develop health literate organizations. I know this afternoon you will hear about learning organizations. It's in the same direction. We need to, on one hand, focus on people's health literacy, but also what kind of response do we give in order to reduce inequalities. And here, I also asked for the paradigm shift that we talked about this morning, moving from a provider-centered care system towards what was some years ago the mantra, the buzzword, patient-centered, patient-centered, patient-centered. But what I really want us to do is to have a people-centered where we respect the expertise of our professionals and what they know, and also the expertise of our people, of our patients, to make that match. But it requires that we rethink our roles. So professionals would be more like knowledge brokers, not the God, but a knowledge broker that can help facilitate the best treatment and the best match. And it also requires our people, our patients, to reflect on their own situation. And can it be done? Lego. I can't hide it, coming from Denmark. Sometimes it's good to think out of the box, because when it's so complex, the issues we are trying to solve, let's think out of the box. And what would the world be without Lego? Not very good, eh? And that was the case 10 years ago. Lego was at the edge of bankruptcy. They were losing money. They had to sack a lot of people. It was at the edge where they actually had to close the business as a world-famous business. And we were all shocked because it came as a bomb. It was talked about in Denmark because a lot of people are employed there. It's one of the world-famous brands. It has meant a lot for us for generations. You know, how could it come to this? Then it is a family-owned business, and they hired a new young director, a new CEO. And he said, we need to do a turnaround, we need to do a change. And he analyzed Lego as an organization. And he realized it was very much one-way communication. You know, we have the designers, they design the Lego models, and they distributed it. And yes, they knew the philosophy is that you can take it out and apart and build up new. But actually, you know, they put so much effort into it. They thought they had made the best models. We know best. They had a very rigorous system in terms of ordering products and delivering, and in terms of distributing their products. And it meant a couple of times that for Christmas sales they had produced too little, and for other things too much. So there was absolutely no match between what the customers wanted, the kids, and what they had produced. There was no flexibility in the system. As I said, bankruptcy was coming up. And it was very much Lego as its own entity. We know best, and you have to follow our way, follow our instructions. What he did, the CEO, was that he changed the culture. So he said, we need to listen to our clients, to our kids, but also to the adults, because they realized there was a big community of adults buying Lego and building Lego and meeting every year. He did research on the kids and how they played. He financed several PhDs looking into play patterns and so on, and how it was actually being used. He said, we need to know the reality, we need to know the evidence. What is going on and how can we influence it? We need to speak to the customers we have. They put up new hotlines where people could call in if they have any ideas. They put up that if you build a model, you can put it into their website, and if it gets more than 10,000 likes, they may produce it. So they suddenly had this dialogue with their customers. And he said we changed completely. Before we had a focus on ourselves, but they changed it to have a relentless focus on the customer's need. And they carefully monitored the sale and the production, and they changed the system so they could easily produce depending on what was demanded. And that was not the case before. More value for money and trying to minimize the waste and the inefficiency. And the co-production of products, which had never happened before. Again, if anyone out there in the world had a good idea to new models, they could put it in, they would take contact, and they would do it. So identifying the problem, thinking what would the world lose if we don't have Lego, make it much more customer-centered, try to be the best, be really, really ambitious about being the best. And then he said, it's practice, practice, practice. Can we make this turn around? Can we identify the real problems? Being very practical. What are the barriers? What would the world lose if we don't have any health systems? Can we change to the people-centeredness? Will we do it? Can we do it? Practice, practice, practice. I'm not sure. Sometimes I'm not sure, sometimes I think, yes, of course we can. Canada is also one of the better ones that have actually focused on it for a long time. They say it's all about public involvement, changing from one direction communication to our partnership, thinking in partnership. Virginia Mason Medical Center, I don't know if anyone is familiar with the work. They said patient is not in the center, it's the top. It's the only thing we are here for, the patient. And they changed all the procedures. And if you read the books about them, their CEOs and their directors said, yes, there were people who didn't want to join this journey because it was too much for them. It broke their routines, they broke their way of thinking. But they relentlessly try to be the best for the patient. They try to create teams that work around the patients. They have their values, and they keep reminding themselves that this is what they're doing, this is why they're here, the same as Lego has done, and Lego has had a growing curve upwards for 10 years. Only 2 months ago now, they had to realize the trees doesn't grow into the sky. Huh? So now they had to adjust. The same with Virginia Mason, patient satisfaction. People working there are much more happy because they see that they have a good progress. From the US, we got an example on how to design health literate organizations, and there's a list of 10 attributes. Leadership, that you involve patients in all planning, evaluations, and improvements, and that you train the workforce, include our customers and clients, that we try to meet the needs of everyone, so also those vulnerable and hard to reach, that we communicate effectively without medical jargon, simple language, but not so simple that we personalize people. Use easy to use the materials. Also realizing that there are some very difficult situations that we also had examples of this morning, where it's not as easy to communicate or hear what people want. And then having the transparency in terms of costs, for example, in terms of insurance and so on. A lot of surveys show that people don't really understand their insurance plans and what they are entitled to and why they should have an insurance plan. In Ireland, they made an audit for healthcare settings, and in the UK, they, in the city of Stoke-on-Trent, they actually made a local deal with the general practitioners that they would get extra paid if they looked at health literacy and took action on it. So there are many different ways, many different levels where we can do it. But it comes back to the empowerment of our health professionals. We need people with the human touch, where we are not reduced to numbers. And I know we all think we are not reducing our patient as numbers, but it's how it come out because of the constraints. Being knowledge brokers, being able to convey the complex messages and make them simple, thinking not only as a burden disease-oriented, but human development-oriented. This person will leave us again and try to have a life with their loved ones. How would this develop, how would this impact the rest of their life, what we're doing there? And I know we all try to do our best. That's why we're here in the healthcare sector. But why is it then that we have these problems? Why is it that, in fact, some people live 10 years less than others? So there are still, if we think we do good, we can do better. I also want to take this example, thinking out of the box. This was our first Danish astronaut, Andreas Mogensen, and he went into space last year, and we're all very proud of him. But there is no such education as an astronaut. So he did it all on himself. He had a vision. He's not living in the US. We have the European Space Agency based in the Netherlands, but their competition is, of course, very, very high. So he just kept on building on his education, thinking, eventually I will fly into space. So he did a PhD in engineering. He lived on, did work for oil platforms and so on, very tough work. And he applied, and he was elected out of 8,000 people, and eventually one of a few team. And why do I think about an astronaut and connect it to health literacy? It's because part of their education is that they have to, after they've been on a space mission, they are obliged to go out and speak to everyone. If the Queen calls in Denmark, he will meet her. If the kindergarten calls, he will go there, schools, students, everyone. He will have to meet them, and being able to convey complex messages in a simple language. And he's trained in that. And I thought, if he can do it, we can do it. And the best of it is that he's such an inspiration because you see the smile on his face. So no matter how many barriers he has to cross and how many mountains he had to climb to get there where he is, he's so happy with what he did. And I think that proudness we should also bring with us when we talk about how to improve health literacy. And the questions you get is that, what do you do if you lose a tooth in space from a small child? Or how do you go to the toilet, and so on? And then you also have to do research for students. So it's a very great skill, and I would love that we could have this in our medical schools and nursing schools to improve this communication. But we also need the change from the political side. Health literacy is a political choice. And what we see now is that many countries try now to make health literacy strategies. And why do they do it? Because it's evident. We have all the research. It's measurable. We can say if it's low or high literacy. It's feasible. It's actually sometimes very low practical things that needs to be changed. And it's definitely supporting equity. So for politicians, it's quite easy to buy in on this one. And they will save a lot of money. They have the economic argument to it. So that's the future for Europe, that if politicians decide, then our organization, health organizations, can follow the mandate. And we have it already from the World Health Organization, from the European Commission. So there's no reason to wait. It's the basis and condition for participatory approaches. Oh, sorry. It's the catalyst that can help the wheels run a bit more smooth, speed up the processes without inefficiencies. We have to go away from one size fits all. We have to meet people where they are. This is the Danish philosopher Sørensen. He says, if one is truly to succeed in leading a person to a specific place, one must first and foremost take care to find him where he is and begin there. We've had a bit the Lego way of thinking, oh, you come all to us and we will get you a vaccination shoot. But a lot of people don't come to the doctor to get the vaccination. So what if we go to the supermarket, to the mall, with the bus and give them the shoots, or to the kindergarten? We have to meet people where they are, rethink our services. Give them the support that they need. Looking at the people, listening to them, hearing their stories, understanding their life, their values, their vision, and what they want, and then give them and support the material. It may sometimes cost a bit more, as you see here, there are more boxes. But eventually you all get the fruit, and that's really our point, that's our mission. So it takes an investment in health literacy to create health literate people, organizations and systems, develop policies that can support it, and it takes leadership and it takes courage, because you're going upstream if you join. But I hope you will face this challenge and be the change with me. Thank you.